All right, folks, welcome back to blood vessels. This is the last blood vessel lecture. And so it's the last lecture before your next test, which will be the cardiovascular system. So here we go. This is showing you blood flow in different tissues with different amounts of activity. Now, recall that at any given time, we shut down most of our capillary beds and we open only those capillary beds where the tissue needs oxygen and nutrients. So you can see that in skeletal muscle, if you're at rest, you might have 1.2 liters per minute or 1,200 milliliters per minute. But if you start doing some exercise, you start running or climbing stairs or something, you can 10 times that. So the amount of blood flow into that tissue could be 10 times what you would have at rest. You can go down through the rest of these tissues. Certainly, this is not something that you should memorize at all, but you should get the gist of it. And the gist of it is that with many of these tissues, you can double, triple, and even 10 times the blood flow with some given activity. Now let me point something out to you here. Let's look at the brain. At rest, your brain's going to get almost a liter of blood a minute, so it's 750 milliliters per minute, 3/4 of a liter. With light exercise, your brain gets 750 milliliters per minute. And with strenuous exercise, your brain gets 750 milliliters per minute. Your brain gets the blood it needs no matter what else you're doing. And of course, unconsciousness ensues if your brain doesn't get the blood it needs, and you can get strokes and things like that if you want to occlude blood vessels in your brain, if that happens. So your brain preferentially will always get blood. No matter what else is going on, you don't shut down these capillary beds in your brain. Everything else here you can see changes. Now, one more thing I want to point out, and I don't want you to memorize these numbers, but look at this. Look at these miscellaneous tissues. Well, at rest they'll get, this is a sum of all of these miscellaneous tissues not listed here. At rest they'll get 600 mils per minute. But as you start exercising, they get less. Well, that should make sense, really, because you only have so much blood in your body. Say you have 5 liters of blood in your body, and you're going to have more flow into your skeletal muscles. Well, that means less is flowing someplace else. So less could go to the skin, and less could go to the viscera, and less and less and less. Well, something has to get less. So you can see some instances here where we have less blood flowing from a particular tissue or organ when we start exercising. And why? Because more is flowing to our muscles. So this is just change in blood distribution with different activities. And just understand the gist of it, the pattern, don't memorize numbers by any means. This is showing you, this is really just a summary of previous chapters. It's showing you cardiac output, heart rate and stroke volume, and remember heart rate times stroke volume equals cardiac output. So it's showing you that for whether you're a trained athlete or a non-athlete, whether you're at rest or exercising maximally. So that's what it's showing you. Now look at this. Let's compare. Let's only change one variable at a time. So let's look at maximum activity, and let's look at a non-athlete versus an athlete. That's only changing one variable. Of course, the athlete has cardiac output that far exceeds the non-athlete. Let's look at them at rest. At rest, the non-athlete has 5 liters per minute. That's his entire blood volume approximately. And the trained athlete has 5.3. That's only 300 milliliters higher, but they're both at rest, so you wouldn't expect that to be drastically different. Look at the heart rates, and we've mentioned this before. At rest, the non-athlete beats 83 times a minute, but the athlete only beats 53 times a minute. Remember, we said this. We said that if cardiac output is heart rate times stroke volume, and because of the high end diastolic volume, we said stroke volume equals end diastolic volume minus end systolic volume. That's what we said. Because of the high end diastolic volume, we have a high stroke volume. But if we keep cardiac output the same, then heart rate goes down. Because with fewer heartbeats, I can pump the same amount of blood. So you can see that there. All right, I'm not going to go through any more on here. You can look at it and reflect and consider and think about it. I think we've been through most of this material here. All right, so this is some cardiovascular adaptations. This is important. Here we are with normal blood pressure, normal blood pressure and volume. All right, and then for some reason we start hemorrhaging, extensive bleeding. We are hemorrhaging right here, or maybe you just went and donated some blood. Okay, let's follow the long-term hormonal response first. So what happens? You start hemorrhaging and your blood volume decreases. Well, one thing you know already is the renin, angiotensin, aldosterone system. You know that, and here it is, angiotensin 2. Now you already know what angiotensin 2 does. It leads to higher ADH and it leads to higher aldosterone. In addition, recall that with a hypoxic kidney, a kidney that's not receiving the amount of oxygen it's used to, it will release erythropoietin, and that'll go to the bone marrow and tell your bone marrow to make more blood cells. All of this increases blood volume and helps to bring you back to homeostasis. Okay, let's do the other part. What does the nervous system do for us? Well, what the nervous system does for us is it will vasoconstrict and raise your blood pressure. Here's the vasoconstriction right here. Another thing it'll do is venoconstrict, and it is vasoconstriction, but it's really specific. Venoconstriction is vein constriction. Now let me remind you about something. At any given time, most of your blood is in your veins. And it's something like about 60% of it. Now, if you constrict your veins, what you do is you hold less blood in your veins. Well, where did it go? Your arteries, your capillaries. So venoconstriction mobilizes the venous reserve. That's what it does. It mobilizes the venous reserve and pushes that blood that's holding that reserve that's holding 60% of your blood into other areas of your body, like your capillaries and in your arteries. What else do we do? Well, we stimulate the cardiovascular center to increase heart rate and cardiac output. And you know that the sympathetic nervous system does that. So these things are going on. All of this returns us to normal blood pressure and normal blood volume. Okay, so that's a cardiovascular adaptation. This is showing you the circuits, the systemic circuits and the pulmonary circuits. As you know, that with the pulmonary circuit, the arteries are colored blue because they haven't picked up oxygen yet, and the veins are colored red because they have picked up oxygen. Whereas in the systemic circuit, the veins are all blue because they're partially deoxygenated, and the arteries are all red because they're oxygenated. All right. This is showing you a picture of the pulmonary and systemic circuits. Well, this is just the pulmonary part of it. And what it's saying to you is in the pulmonary circuit, oxygen goes from my lung into my blood. And in the pulmonary circuit, CO2 goes from my blood into my lungs so I can breathe it out. Now, this is probably intuitive to you at this point, but when we get to chapter 23, we're going to talk about the dynamics of gas exchange, because there's more to it than just saying that. And actually, I take that back. There's not more to it than just saying that, but we put numbers to it. We put pressures on that. We say, why does oxygen move into the blood? And we look at the pressures of oxygen in the lungs and in the blood. So it really doesn't change the story. It's just that we put numbers to it. So that's the pulmonary circuit. And then in the systemic circuit, oh, this is still the pulmonary circuit. So this is still the pulmonary circuit. Oxygen going into the blood, CO2 going into the lungs. And then in the systemic circuit, the opposite's going to happen, and I have a picture of that in a second. This is showing you the systemic circuit first, and a lot of these blood vessels you learned in lab, so you can see a lot of them there. You can see most of your blood vessels in your legs there. Hopefully you recognize a lot of those. All right, now there's one thing we haven't covered, and it's similar to the pulmonary circuit, and that is the umbilical circuit, the fetal circuit. Think of this. The baby doesn't pump blood to the lungs. There's two bypasses we talked about. There's the ductus arteriosus, and there's the foramen ovale that turns into the fossa ovalis after birth. These two shunts keep blood from going to the lungs. Why would the baby pump blood to the lungs? The fetus is not breathing yet. It hasn't been born yet. But where does the fetus get its oxygen? And as you know, it gets it from the placenta, from mom's circulation. So we're going to look at fetal blood flow and see how it is an exception to the rule as well. All right, so let's look at this. Now, as you know, arteries always carry blood away from the heart. And veins always carry blood back to the heart. So if you look right here, if you look at this descending aorta right here, see this aorta going up and going behind the baby's heart and coming down through? Here's a descending aorta. And you look at this, you'll find some umbilical arteries coming off that descending aorta. And here it is. Here's the umbilical arteries. All right. Now these umbilical arteries are not red. Why not? They haven't gone to the placenta and picked up oxygen yet. But the umbilical arteries go out to the placenta. They travel side by side with mom's circulation, and they pick up the oxygen from the mom. And now they return to the baby through these umbilical veins, which are red. Now, why are these umbilical veins red? Because they just picked up oxygen from the mom. And you can see the umbilical vein fuses with the inferior vena cava. Now what you're going to say to me is you're going to say, so in the fetal circulation, the baby is always mixing oxygenated blood with deoxygenated blood? You bet. That's always happening. But it's enough to give a baby enough oxygen to survive, obviously, because the baby survives and is born. So all this oxygenated blood comes back and mixes, goes into the right atrium, right ventricle. By the way, if it goes through the foramen ovale to the left atrium, then the left ventricle, and if it misses the foramen ovale, it goes through the ductus arteriosus into the aorta, so it's bypassing the lungs, and then it goes out to all parts of the body, and some of it goes back and gets some more oxygen. So this is fetal circulation, and you can see that the umbilical arteries aren't fully oxygenated. That's why they're that purple color. And the umbilical veins are fully oxygenated, and that's why they're red. All right, fetal circulation. Now, we've already talked about these things, but I'll remind you, a fetal heart has a foramen ovale that's open and a ductus arteriosus that's open. And then after birth, this closes and becomes the fossa ovalis. And the ductus arteriosus closes and becomes the ligamentum arteriosus. There are diseases where these don't close. Patent ductus arteriosus means it stays open. And now you've been born, and now you're breathing, and now you're still mixing deoxygenated and oxygenated blood. So that's a disease. Patent ductus arteriosus is a disease of the ductus arteriosus not closing after you're born. I think I have that listed. Let's look at it. There it is. Patent ductus arteriosus, PDA. Patent foramen ovale. The foramen ovale stays open. Tetralogy of flow is 4 conditions. You got pulmonary stenosis. Where is that? Here's 1, 2, 3, 4. That's why it's called tetralogy. Number 1 is pulmonary stenosis. It doesn't say, oh yeah, it does right there. It says it right there, pulmonary stenosis. And then it explains to you what that means, an abnormal narrow pulmonary trunk. The interventricular septum has a hole in it. You can see that right there. That's part of the tetralogy of flow. So there's a big hole in the interventricular septum, and you're mixing deoxygenated and oxygenated blood. All right. Uh, the aorta sits on top of the septum, so it's just a deviated aorta is really what it is. And I'm trying to see where they're showing you that. They're really not. So what it says, the aorta originates where the interventricular septum usually ends. So the septum usually ends, and that's where the aorta is originating. So the aorta is deviated. And because of mixing oxygenated and deoxygenated blood, because of that, the right ventricle becomes enlarged. Because usually the right ventricle has a very easy job. Usually it pumps blood just a couple inches to the lungs. From your heart to your lungs, just a couple inches. But now you're mixing oxygenated and deoxygenated blood. And how does our heart respond to that? You get right ventricle hypertrophy. So this word enlarged could also be the word hypertrophy. Okay, that's tetralogy of Fallot. This is this is one single lesion. It's found in the tetralogy of Fallot, but in this case it's found all by itself, and it's the ventricular septal defect. Okay, so let me talk about the patent foramen ovale and the patent and the ventricular septal defect. What do? Well, doctors might wait and see if it closes. And now think about this before you throw your arms up in the air and say, what do you mean? Well, the option is open heart surgery for a baby, a newborn baby. And these things might spontaneously close. So the baby and child will be observed very closely, and they will do surgery if the foramen ovale or the ventricular hole doesn't close. But they have been known to heal and close spontaneously. So the doctor might give it years, and I do mean years, not months, but years. If it was a real, you can see these by imaging, by the way, by ultrasonography. You can see these. Doppler, which is ultrasonography, really. So they'll monitor them, and if it leads to other problems, then they certainly will do the bright lights and cold steel and go in there and fix it. But it may be a wait and see to see if it closes automatically. This is not just happening in the heart. This is called a transposition. And when you have transposition of the great vesicles, that means the pulmonary trunk and the aorta, you have other problems as well. Other organs are transposed as well. So this is a small part of a bigger issue, and that's what this is called, the transposition of the pulmonary trunk and aorta. And this is showing you a normal heart. And then we can start talking about what happens when you get older. All right. For one thing, when you get older, your bone marrow responds less readily to things. It doesn't respond to erythropoietin as much, so you get a decreased hematocrit. Well, the thing is that you're running around with a lower crit. Your crit usually is in the mid 40s, say 45% red blood cells. That's your crit. But your activity goes down as you get older too. So it's not something, you're not really, with a few exceptions, you're not really running marathons anymore. So even though you have a decreased crit, you really might not notice a significant change in lifestyle because you're already less active. So this might not be a big deal, having a decreased crit. By the way, having said that, sometimes the elderly females show an increase in their hematocrit. Now, why would that be? That would be because of menopause. They no longer are menstruating once a month. Okay, number 2. This is huge. As you get older, you have a predisposition to deep vein thrombosis and pulmonary embolisms. This is saying just a peripheral blockage by a blood clot. So yeah, you're going to get these thrombus, these clots in your veins. And the 2 serious ones are deep vein thromboses, which is abbreviated DVT, and PE, pulmonary embolism. These must be treated. They can be deadly. So when you have a tendency to get these blood clots, if the doctor finds out that you do have a tendency to get these blood clots, by the way, how do they find out? They run this test on you called a D-dimer. What happens is when your normal fibrinolytic system breaks down these clots, D-dimer goes up. We have a high sensitivity D-dimer test in the lab that can see if this is elevated. And if it is, then you're likely to have a deep vein thrombosis or a pulmonary embolism. These can lead to death, so you have to treat them. If it's found early, you have a very innocuous treatment called aspirin. 180 milligram baby aspirin a day, and that's not a huge deal. You might have to take it the rest of your life, but it could prevent more rigorous treatments like Coumadin, and not that that's horrible, but it does have some problems associated with it. And now they have a whole bunch of factor 10A inhibitors and factor 2A inhibitors. So lots of treatments for these. Something that happens when you get older, you get varicose veins. The valves in your veins become weakened and invert, and blood pools in your legs. And by the way, the pooling of blood in your legs leads to deep vein thrombosis. And if one of those thrombotic lesions breaks off and lodges in your lungs, you'll get a pulmonary embolism. So some of these are interconnected. So the venous valve lesion can lead to a thrombus in your veins. By the way, a thrombus in your veins can create pressure in your veins and lead to lesion to valves. So you see this positive feedback effect here, and this is age-related changes in your body. Your heart doesn't beat as efficiently as you get older, so you have decreased cardiac output. Your conduction system might not respond as it did when you were younger, so you might end up with some arrhythmias as you get older. Your SA nodes membrane may not leak as regularly. Remember why you have a sinus rhythm. It's because your SA node membrane leaks, and it hits threshold and spontaneously depolarizes pretty regularly. Well, the changes in these membranes will change your conducting system, and you could get some arrhythmias. Let me see what else. Obviously, as you get older, you get atheromas built up because you've been eating cholesterol for the last 80 years. There was never one particular day where you had too much cholesterol, but the sum of all the cholesterol you ever ate over 80 years will lead to some atheromas. By the way, I would say if you've made it 80 years without significant atheromas, you're doing pretty good. All right, that's about it. Let me see, is there anything here? Oh, I'll talk about this. This does happen. We see this all the time. Some of the elastic tissue in your blood vessels weakens as you get older, and this weakening of the elastic tissue can lead to bulges in your blood vessels, and these bulges are called aneurysms. Some aneurysms can burst and you can survive because they're a very small blood vessel, but if you have an aneurysm in your aorta, they call it a AAA, abdominal aortic aneurysm. This is a huge descending aorta, as you can imagine. You learned it already. If you have a AAA burst, unless you're lying in the hospital right then and there when it bursts, and even then it would be touch and go. If you have a AAA burst, you're likely not going to make it. You're not going to make it for the ambulance to get you and rush to the hospital. It's a huge artery. You would bleed out into the abdominal cavity very quickly. All right, we already talked about the thrombi and the atheromas and the atherosclerotic plaques. So these are all things that happen as you get older. And that's it for the blood vessels.